So without further ado, I'm going to have Dr. Vaidya join us again. Thank you for your discussion this morning, and the floor is yours. All right, thank you.
Okay. So I am excited to be back up here again to talk with you about a pharmacotherapeutic approach to pediatric obesity. Something that I feel very passionately about and has changed the field of obesity medicine, especially over the past few years. I have no financial conflicts of interest to disclose. I will be talking about some off-label use of medications in instances where there are not affordable alternatives. So my goals today are to review the available pharmacotherapeutic options for pediatric weight management. I'd like to review the data for efficacy for some of these newer medications, review the clinical reasoning in choosing a medication, and then at the very end, I'm going to talk about a clinical scenario to try to pull everything together and go through sort of how I think about choosing medications. So the guidelines in Key Action Statement 12 state that pediatric healthcare providers should offer adolescents 12 years of age and older with obesity pharmacotherapy according to medication indications, risk and benefits, and as an adjunct to health, behavior, and lifestyle treatment. Unfortunately, there was not enough data for the younger age groups, so children between 8 and 11 years of age may be offered pharmacotherapy. That was their consensus recommendation. I want to stress an underlying theme. There is no evidence that supports weight loss medication use as monotherapy. And that's really important, something that I can pass on to all my patients before I start any medication. So PCPs who prescribe weight loss medication to children should provide or refer intensive health behavior interventions to patients and families as an adjunct to medication therapy. And that's really important. In fact, all the clinical trials were in the context of lifestyle change and counseling. So let's start off by talking about the off-label weight management medications that we have: metformin, topiramate, and lisdexamfetamine. Metformin is probably one of the oldest medications that's been used in pediatric weight management. It's an anti-diabetic agent, increases insulin sensitivity, and decreases blood glucose production. It's FDA approved for children 10 years of age and older with type 2 diabetes. Off-label, it has 3 specific uses: prediabetes, PCOS, and prevention of weight gain with atypical antipsychotics. So in prediabetes, there is actual data in the adult population and some in adolescents that suggests that starting metformin in the context of lifestyle change can prevent progression to overt diabetes. So it can be very useful, especially if we have patients who have hemoglobin A1Cs that are inching closer to diabetes. In PCOS, it can be helpful in individuals who have a lot of insulin resistance and menstrual irregularities, and sometimes kids who start on metformin can have normalization of their periods, and as well as treatment of metabolic syndrome. And then the prevention of weight gain with atypical antipsychotics is an important one to think about. With atypical antipsychotics such as Abilify, most of the weight gain happens in the first 6 months. So starting a patient on metformin in that early time period can really mitigate rapid weight gain. The dosing for metformin is 250 milligrams to 500 milligrams orally, once to twice daily. And you can increase up to 2 grams to 2.5 grams depending on age and effect. It needs to be taken with a meal. If you don't, you're going to have a lot of GI distress. And you can change to extended release once a day for better compliance, and sometimes the GI side effects are less with the extended release. Adverse effects include bloating, nausea, flatulence, and diarrhea. Rare side effects include lactic acidosis and hepatic toxicity. BMI reduction, unfortunately, is fairly minimal with metformin. In the data that the guidelines, in the research studies that the guidelines reviewed, what they found was about 2/3 of adolescents who are on metformin lost about 1 BMI point, and 1/3 it didn't make any difference. The children or the adolescents who did lose weight on metformin tended to be individuals with severe obesity, as well as a comorbidity such as PCOS or prediabetes. So this can be a very useful medication as an adjunct to IHBLT when there are the specific indications that we just spoke about. Topiramate is another medication that is used off-label for appetite suppression and weight loss. Unclear exactly how it works. It is, of course, FDA approved for children 2 years of age and older with epilepsy, and for children 12 years of age and older with headaches. Dosing is 25 milligrams to 100 milligrams daily, and adverse side effects include cognitive blunting and somnolence. It's a potential teratogen, so we need to provide counseling and birth control as needed to our female patients. Lisdexamfetamine or Vyvanse, a stimulant that is FDA approved for ADHD and for binge eating in patient 18 years of age and older. Off-label, however, it can be used successfully in children and adolescents who exhibit a loss of control with food. Dosing ranges from 10 to 70 milligrams. Adverse effects include mood changes, headaches, increased blood pressure. There is unfortunately no evidence for its efficacy in the treatment of obesity. However, I will say that our clinical experience has been in the right clinical scenario, someone who has a loss of control with eating and also has comorbid ADHD, I found it can be very helpful to help children improve their eating pattern. The situations where I really don't like to use this medication are kids who are skipping meals, especially breakfast, because what I find is that they are skipping breakfast, you put them on Vyvanse, they're going to skip lunch, and then when the medication wears off, they develop rebound hyperphagia, and they really don't develop a healthy eating pattern. So let's change tracks and go to the FDA-approved weight management medications that we have. We have orlistat, phentermine and topiramate, and then the GLP-1 receptor agonists. So orlistat is an intestinal lipase inhibitor which blocks fat absorption. It is FDA approved for children 12 years of age and older with obesity. Dosing is 120 milligrams 3 times a day. Adverse effects of this medication include steatorrhea, fecal urgency, flatulence, vitamin deficiencies. And I have to say that if you talk to adolescents about these side effects, usually they are not willing to start this medication. Rare side effects include liver toxicity. This is not something that we use often at all. In fact, I can say in my career I've used it twice. BMI reduction is fairly minimal. It is available over the counter. I think it's just good for us to know it's available over the counter, and it's called Ally at a lower dose. Phentermine is a medication that has been around since the 1950s. So we have a lot of experience with medication. It's a sympathomimetic anorectic, which is a norepinephrine, serotonin, and dopamine receptor reuptake inhibitor. It is FDA approved for children 16 years of age and older for short course treatment, so that's for 12 weeks. It is contraindicated in situations where there is cardiovascular disease or uncontrolled hypertension, and dosing ranges from 7.5 to 37.5 milligram. Most adverse effects are elevated blood pressure, so you really need to monitor blood pressure with kids on phentermine, headaches, dry mouth, tachycardia, and dizziness. Rare side effects include pulmonary hypertension and valvular heart disease. But one of the biggest problems with this medication is the efficacy really wears off fairly quickly. Usually if you start someone on this, the first month they're very excited about their progress, and then by month 2 or 3, they don't feel much with this medication. So that's one of the biggest drawbacks with phentermine. Phentermine and topiramate, however, is another story, and this has really been an exciting tool in the management of pediatric obesity. So phentermine and topiramate, the brand name is Casimia. And it was FDA approved at the end of last year, and this was based on a 56-week randomized double-blinded trial with 223 enrollees who received lifestyle counseling. And individuals who are on the study drug experience a 10.4% decrease in BMI compared to placebo in the top combination. And individuals on mid-dose combination had an 8.1% decrease in BMI. Patients who received the study drug also had improved triglyceride and HDL, however, it wasn't statistically significant. And this medication is contraindicated in hyperthyroidism and glaucoma. If you prescribe Kisimia, they have a very specific dose escalation schedule. So you start off with a really low dose for 2 weeks, move up a dose, a level for 12 weeks. If a patient doesn't lose at least 3% of their BMI, then you move to the next level and you do that level for 2 weeks and then go up to the final dose level for 12 weeks. If at the end of this titration, this dose escalation, they haven't lost at least 5% BMI, then you would stop the medication. Adverse effects of this include mood disturbances, dizziness, dry mouth, metabolic acidosis, and paresthesia. And negative pregnancy test is recommended at the beginning and periodically as needed. So let's switch tracks to now an injectable medication, the glucagon-like peptide receptor agonist. A lot of press about these medications. I feel like I read something about them almost every day or every week, something new. They decrease hunger by slowing gastric emptying and targeting satiety centers in the brain. There are 2 medications that I will be talking about, both of which are FDA approved for the use of children 12 years of age and older with obesity. Common adverse effects include nausea and vomiting, and they are contraindicated in with someone who has a personal or family history of medullary thyroid cancer or a personal history of multiple endocrine neoplasia syndrome. First one I'm going to talk about is liraglutide. Its brand name is Saxenda. This medication was FDA approved back in 2020. And this FDA approval was based on a study that showed 56 randomized double-blind placebo-controlled trial with a 26-week follow-up period with 251 enrollees who received lifestyle counseling. And what they found is the study participants who were on the medication, on liraglutide, achieved 4.6% decrease in BMI compared to placebo, or 4.5 kilo absolute decrease in body weight. There was no difference in cardiometabolic variables between placebo and treatment arm. And so, interesting data here, but this medication didn't necessarily get a ton of traction. And this also has a dosage escalation schedule. So you start off, they're little injectable pens that you can titrate the dose up, and you start off at 0.6 milligrams every day. And then at the end of a week, you can go up another 0.6 milligrams to a max dose of 3 milligrams. Semaglutide, of course, is the one that's the hot medication that we're hearing about and people are asking for and talking about often. The brand names are Ozempic and Wegovy. Ozempic is actually only FDA approved for individuals with diabetes. Wegovy is the weight loss formulation, and Wegovy was FDA approved in January this year for children 12 years of age and older. And that was based on the STEP teen study, which concluded towards the end of last year. This was a 68-week double-blind placebo-controlled trial with 200 enrollees who received dietary counseling and physical activity counseling every 2 weeks up to week 20 and then every 4 weeks. Patients who received the study drug achieved a 16.7% decrease in BMI compared with placebo, or 15.3 absolute change in body weight. The authors of the study just actually published another paper where they re-looked at their data. And one of their conclusions was 44.9% of patients in the semaglutide group achieved a normal BMI or overweight BMI. which is really quite remarkable. And what is even more exciting is all the patients in the semaglutide group had improvements in their lipids, waist circumference, ALT, blood pressure, and hemoglobin A1C. So not only are we seeing impressive BMI reduction results, but more importantly, we're seeing really tremendous change and improvement in cardiometabolic health. The most common side effects are GI, nausea, diarrhea, vomiting, abdominal pain, and GERD. Less common side effects, which were noted in adult studies, as well as the adolescent study, the STEP teens, pancreatitis, colitis, and cholecystitis. Hypoglycemia was really only a problem with individuals with type 2 diabetes who are also on other medications, other oral hypoglycemics. Acute kidney injury, but that was noted in patients who developed severe GI symptoms leading to severe dehydration, hypotension, rash, and urticaria. This medication also has dosage escalation. You start off with a 0.25 milligram dose weekly, subcutaneously weekly, and then you go up every 4 weeks. The maintenance dose is 2.4 milligrams, and that's what you can get with Wegovy. I will tell you that my clinical experience, however, has been that I often don't need to escalate to that dose. So I have patients who are doing really well, even on 0.25 milligrams. So I don't think, even though that's what's recommended, I don't think you always need to go up. I mean, and my philosophy is we really want to have the lowest dose that's effective. So let's kind of summarize this with a case study. And this is a patient that I saw in December of last year, 17-year-old young lady who presents for weight management. She has been heavy. She describes herself as having been heavy since early childhood, but she gained weight rapidly over the course of the pandemic. She attributes her weight gain to large portions and a deterioration in the quality of the foods that she's been eating. She has tried to improve her eating habits, has lost 10 pounds, but cannot sustain this weight loss, and she is really frustrated. She reports frequent loss of control with food almost daily and skips breakfast most days of the week. She has a past medical history of insulin resistance, prediabetes, hypertriglyceridemia, fatty liver disease, and snoring, suggestive of possible obstructive sleep apnea. Family history is significant for strong history of obesity and a maternal grandmother with diabetes. She's on no medications. She lives with her parents, siblings, and her grandparents. And then on physical exam, her BMI is 43.6, which is diagnostic of class 3 obesity. She has positive findings, including hyperpigmentation around her neck and axilla and striae on her abdomen and arms. So in summary, we have a 17-year-old class 3 obesity with acanthosis nigricans, prediabetes, fatty liver disease, frequent loss of control with food, possible obstructive sleep apnea. So the first thing we talked about was family-wide modifications. So important to make sure that everyone, especially in a multi-generational household, make sure that everyone is on the same page. We're all working through this together. And she would come to her visits with her mom, who was very invested and was making sure that this was actually happening. And then we talked about other treatment options, medications and surgery. So we went through the different medications. We started off with metformin. She is a candidate for metformin. She has prediabetes. She has signs of insulin resistance. However, metformin would probably not give her a significant amount of BMI reduction, but it's something to consider, and we kind of put that on the back burner. We talked about Vyvanse because she has a loss of control of food. However, she's a young lady who has been skipping breakfast. She doesn't have any ADHD, so I thought, this may not be a good medication for her. Again, there's not a lot of data to show that it's super effective, always with BMI loss. Talked about semaglutide in particular. It's one of the GLP-1s, and the family was very interested in this option. However, as what happens often when we try to prescribe semaglutide, it was not covered by insurance. So we went and we had a discussion about phentermine and topiramate. Because SIMI, unfortunately, many insurance companies just will not cover weight loss medication, and so it's not covered often. But one way that we can get around this is prescribing the two medications separately. And so the way we did this is I prescribed phentermine 37.5 milligram tablets. We were able to get her a good RX prescription or coupon, and she can purchase, she got 30 pills for I think $16. What I wanted her to do was to cut the pills in half. And so she takes 18.75 milligrams of phentermine every morning. So it's about $16 for a 2-month supply. And that was acceptable for this family. And then I prescribed 25 milligrams of topiramate. So she took the two of these together. And I will tell you what happened. And we also talked about bariatric surgery. And so she was very interested in bariatric surgery. One of the things that when we have patients who express early on that they're interested, I always tell them it's better if you are thinking about it to tell us now, because many insurance companies require monthly visits to prepare for bariatric surgery. And so she was interested, so we scheduled her for monthly visits, which was also really helpful because we were able to follow her. If I start someone on medication, I'm going to see them frequently to check for adverse side effects. And so we had her scheduled out for several months monthly. So this is her progress. She lost about 53 pounds over 5 months. Of course, the first time when she came in, I saw this and all my red flags went up and I thought, okay, wait a minute, what's going on? Is she doing this in an unhealthy manner? It's important to always think about this, make sure, of course, we always never forget that we don't want to have someone kind of veer into eating disorder. And so we really checked, we were reassured by the mom who was making all of her meals, was absolutely sure that she was eating in a healthy way. Her BMI came down 8.5 points, 19.5% reduction, and she went from class 3 to class 2 obesity with a BMI of 35.3. But what's even more exciting about this case is her labs. Her hemoglobin A1C was normal lipid panel, no more snoring, normal insulin level, and normal ALT. So she demonstrated significant cardiometabolic improvement. So whenever we have cases like this, and I will be the first to say this is not typical, this is what we aim to achieve. I always like to look, what are the strengths? Why did this young lady do so well? She had a lot of family support. She really had a family that was invested. They all were working together. Her mom is amazing, and she works with her mom. She's not rebelling against what her mom's doing. So they're working really well together. Mom is providing structured, healthy meals, really taking into account all the recommendations that the dietitian was making to the family at each visit. This young lady had had an amazing response to the anorexigenic medication combination that we prescribed. And she was very motivated. This was something that she really wanted to do. So what are the next steps? We do have this success, but we need to continue to support for dietary modifications. Not something that we can say, okay, you're great, have a great life. We need to continue to support her. Really recommend children who achieve BMI reduction and increase in physical activity. And this young lady is a soccer player, and she was feeling more positive about playing soccer. She felt like she can do more. So I'm hopeful that that will continue to be a part of her life and she'll increase her physical activity. And we want to prepare for relapse. That's really important, okay? This is, again, as I stressed before, this is a chronic relapsing disease. So we do need to be prepared for this. Some children who do well with medication, you may end up having, they may do fine for a year and then it stops working as well, or they want to come off it and you may have an increase in BMI. And so then we just need to think about other options that are available. And she may end up down the line decide that she needs or is interested in bariatric surgery again. But at this point, I think the fact that she has achieved such amazing cardiometabolic health improvement, we're going to hold the course. So I am available if anyone has any questions. I know that we were going to have a longer Q&A right now.
Maybe a chair up here. So.
Hi, Stephanie Hart. I'm in solo practice in Rockville, and I wanted to ask, when you were talking about use of medications, in particular being able to prescribe the two components of glycemia separately, how long do you keep them on medication? Is there a plan for them to go off medication? How does that work out in the long run for these patients?
And, okay. So that's a really good question. I think it's the way when we start medication, we talk to parents about and patients what the expectation is if they come off the medication. And because it is a chronic disease, they are very likely to gain the weight back. So the expectation is most kids are going to be on the medication indefinitely. Now, you can work on this with them, and I've had children who have been on phentermine and topiramate, and maybe they get to a point where, over the summer, they're really involved with something, they're physically active, we give them 3 months off, but most kids are going to end up being back on the medication.
Great question. Any others?
Hi, I'm Dr. Mittal. I'm also internist and pediatrician in Rockville. My question was very similar, but do you tell them ahead of time that you might be on it lifelong?
Oh, absolutely, yeah.
Okay.
No, that's sometimes also something that people think about when they're deciding between medication and going on to do bariatric surgery, right? Because some patients will say, well, I'm not sure I want to be on this for an indefinite period of time.
Because semaglutide does not have any recommendation to discontinue either, which is also injectable. So
I'm sorry?
The semaglutide, they does not have any recommendation to discontinue.
That's
so
right.
Is it getting approved when you apply for that? Like when you prescribe?
Are we getting
Semaglutide is getting approved for pediatrics right now?
It really depends. It varies. What's interesting is that, and I don't know about you, Alicia, but I'm getting more approvals for Ozempic,
Right.
which is actually the diabetes medication. I have never gotten approval for Wegovy. I don't know.
I have gotten some, but yes, I would say Ozempic does seem to have more success, and Saxenda as well, though I think sometimes there is a little bit of resistance to a daily injectable when they know that there are these weekly out there, but I would say probably Saxenda and Ozempic I've had the most favorable outcomes. They almost all require PAs. Every now and then I send one in that just gets filled, and sometimes I feel like it's an accident. So it is a little bit of the Wild West, but I do have a handful of patients on Wegovy as well.
Do you want to translate PAs?
Oh, prior authorizations.
So I think one of the things that I'd invite our panel and others to sort of chat about is, it's one thing for the guidelines to come out. It's another thing actually for there to be some new recommended medications. Two things, comment about cost, both short-term and long-term for families, as well as I have some comments about payers and how quickly they are or are not sort of acknowledging and responding to the recommendations.
Yeah, do you want me to address maybe cost first? I know that's a big one that comes
You
up.
folks are the smart ones, so that's why we're putting you on the spot.
Yeah, I work between our clinic in Southeast DC in Anacostia and our regional outpatient center in Fairfax. So I see a very broad spectrum of families across different payers and socioeconomic levels. And I do tell people point blank, I don't want anyone paying out of pocket for these medications, even if you have the means. Some people really want to, particularly some of my patients in Fairfax, and I would not pay for that. But it can be very frustrating because we know that there can be such good outcomes. And I would caution, if you have families that are really motivated to find these medications, I have seen some very concerning things happen with compounding pharmacies, with families trying to get these prescriptions from Mexico and Canada. So I think this is a big area we can advocate for, but it is definitely a frustration because there is a lot of inconsistencies across insurers right now for semaglutide in particular.
I think one of the other really frustrating things about the insurance is just the discrepancy and inequity in approvals. So I have had patients with private insurance who I prescribed it, and in the room, the parents will get a notification from the pharmacy that it's waiting for them. And then I have patients with Medicaid who we will go through umpteen million prior auths and appeals, and it still won't get covered. So it is, I will put it out there, it's a real problem because these medications are effective. And when it is covered, I have one family has private insurance, it was not covered. And the young lady came in, she was actually post a sleeve, several years post a sleeve, and had gained the weight back, and her parents were willing to pay for it. And it's about $1,000 plus per month. And she said, this is the only thing that's ever worked. It has changed everything for me. The Washington Post had an interesting article recently written by Ruth Marcus, who's one of the who writes is one of the editors, and it's a really long article, but it was really good to read about her experience personally with Ozempic and how she feels about it and how it changed things for her. And I think it's nice to kind of get that perspective.
Hi, I'm Kathleen Cato from CMPA. Question about those kids with BMIs between like 30 to 35 who don't necessarily have any comorbidities or abnormal labs. Do you medicate those kids, or what do you do?
So that's always challenging when you have a child who has no evidence that there, no current evidence of cardiometabolic dysfunction, right? It's always a challenge. I mean, the data suggests that they will eventually develop something and they are at risk. My personal practice is to use medication in, very case dependent, and I tend to use it for children who have higher class 2, class 3 obesity, or kids who potentially have, I have had some kids who have lower BMIs and maybe have significant fatty liver disease or something like that. And so I guess my answer would be if they have a lower BMI, but if they have a comorbidity, then I would start talking about that.
Yeah, no, I would say my practice is pretty similar. And I think like we talked about in the beginning, right, there's a lot of complex factors, right? And the BMI is a screening tool. And I'll tell patients that as well, right? You may have someone with a BMI of 32 that has prediabetes and NAFL and a lot of these kind of inflammatory, insulin-resistant based complications, and another person with a BMI of 32 who is, on the dance team and has no comorbidities and is not affecting their life at all, right? And so those are the people that I would say this is a screening tool. We're going to check your labs. We're going to make sure we're not missing anything, but just having a BMI in this range doesn't mean that I'm concerned about it. What are your thoughts, right?
Hi, my name is Lakeisha Terrell, and I had a question about the FDA approval for the phentermine topiramate. Is it for the combination pill, or can you prescribe the pills separately and then it's still okay?
Yes, so from the FDA standpoint, the Kysymia is FDA approved for 12 and above specifically. Phentermine is approved for 16 and above, but Kysymia is often not covered by insurance. And I would say in an off-label practice, as we kind of discussed before, that we will sometimes prescribe these individually, both topiramate and phentermine. You cannot really achieve that specific dosing that Dr. Vaidya mentioned because the individual pills are not available in those doses specifically. They're only available as the combination Kysymia. So I certainly have patients that I have done that for and have just documented that it is off-label in that indication, but that this branded option exists with FDA approval.
Christine Saba in Rockville, Maryland. I had a question about the topiramate. When you're Do I keep going?
Yeah, keep
I'm
going.
over here.
Oh,
Hi.
sorry.
I'm like over here. My twin is over there. So when you're using the combination, are you noticing any of the cognitive things in children when you're using it? And do you have to stop the medication? The topiramate and phentermine, or is the phentermine stimulant enough that it covers the cognitive aspect?
Yeah, I definitely think the combination helps. Typically, the doses that we use in the kind of 25 to 50 milligrams of topiramate range have less of that cognitive blunting effects, as opposed to some patients that I see that, you know, are on it at 100 milligrams for migraines kind of doses. But it certainly exists. It seems, I would say anecdotally, that it's worse in older patients and older adolescents, and I don't know why, and maybe Susma actually is more versed in this, but the younger children seem to have less of that cognitive effect, and so in clinical practice, I will often err toward that in our younger patients that need the appetite suppression versus older adolescents.
Thank you.
My experience has been that using, when you have the two of them together, they mitigate each other's side effects. So it's really quite remarkable. I will say that the dosing that I tend to start off, the 18.75 the phentermine and 25 of the topiramate, is low on the topiramate side compared to what's in Casimia. So Casimia, I think it goes up to 90 something, the top dose. So, but I like to start low and to move up as needed. Oh yeah, so for the patient, the case study, what I usually do is 18.75 milligrams of phentermine and 25 milligrams of topiramate. And the main reason why I do that is just because it's very easy to get the 37.5 milligram tablet and just cut it in half. Getting any of the other tablets, it's interesting. I found it difficult to get a lower, like a 15 milligram tablet. There's a 15 milligram capsule, but getting a tablet is really hard. So it's really just going with what's available.
Kathleen Shannon, school-based health in Montgomery County. So you're addressing a chronic relapsing disease with some older teens. To whom do you refer them when they age out of pediatric care?
Very good question. And so we actually do have, we have a list that we give our patients. So we see patients in ideal, if they're already our patient, we'll see them up to 21. But we don't, if they're 18 and older, they probably should be going to an adult practice. And there are several practices. There's one in Virginia that I know for sure accepts insurance. That's the biggest problem, is practices that accept insurance for medical management, but there are a few. I don't know if you know of any. There's one in Virginia. GWs.
And yeah, we do have some listed in the toolkit as well that will be coming out. But yeah, I will say there's much more bariatric focused programs in the adult world. I have found it a little more limiting for adult programs that are similar to ours in terms of more of the kind of lifestyle counseling and medication management option. A lot of them are very surgery focused, but there are a couple out there.
Great. Betty, if you don't mind 1 second before we get started, I'd like to just go back to the question that started or ended our last discussion, which, correct me if I'm wrong, which was essentially related to the IHBLT. And the question was essentially how much time qualifies as one of these 26 to 52 sessions that we can offer to our patients.
Yeah, so I would say from a primary care setting, I think it is something that when we're thinking about those little doses of motivational interviewing and assessment in the context of patients also being involved with other programs, other counseling options, that your piece does not, we don't expect our primary care to have, an hour-long counseling session with a patient. Even 30 minutes is probably a stretch, right? I think even a 15 to 20-minute follow-up visit, when we're talking about really them coming back for a focused discussion, can be doable and very effective.
Maureen Banta in Bethesda, and I have a question how you deal with college students. The question is, they've been our patients for 18 years. They are now leaving us and weight is an issue. Seeing them monthly, they're going cross-country. How do you propose we manage that?
College is a special time. Yeah, and I have a lot of patients that, as we said, they sort of age out at 21, but they really want to, sometimes we'll see them until they're done college. And they will often, for our patients, I would say that are still very, under more intensive treatment, we'll see them back at breaks, right? So I have them come back at their Thanksgiving break and their winter break and their spring break. If they are in state, we will often be able to offer them virtual options, either with our program or like some of the things I shared in the community that a lot of the dietitians nowadays have virtual options. I know ours do at Children's, and I've found that to be really helpful for patients as they're trying to navigate the dining hall and the social scene. So I think utilizing that component of check-in when they're home, virtual options when they're away if they need to, encouraging them to access resources on campus. When they're out of state, that's a little more challenging, right? Because that becomes a licensing issue with virtual.
Actually, I have a question just by show of hands, because some would say that pediatrics actually never really ends, just keeps going and going, but also acknowledging that, at least in many parts of the DMV, finding an adult care practitioner, an internist, is actually really hard or expensive. And I was just sort of asking by show of hands, I know we're all struggling to sort of get our practices staffed and catch up on all the kids that we need to be seeing. How many folks are routinely seeing kids after 18 years of age, just by show of hands? Great, look all around, look at all the hands up. How many folks are continuing to see folks after 21 or 22 when they're still covered under parents' insurance? Hands up, hands up. Because it's hard finding care for those not so young kids anymore. Okay, we may talk about that more at our Business of Pediatrics meeting in December, but thanks. Back to you both.
Hi, I'm Katie Edwards, Annapolis Pediatrics. I just want to ask sort of a kind of a higher level question. I mean, I remember when like Prozac and Zoloft came out, there was a lot of talk that it took like 5 or 10 years before like we were comfortable on the ground prescribing that. And I guess I'm kind of waiting for some kind of permission or something from maybe you or something else. Like, when am I going to go back to my practice and prescribe these? Can I do that now? I mean, I've then got like, we're a large practice, so it's not like I can just do it and nobody else can. And so I just have no idea when to like write my first prescription for this.
So I think that's an excellent question. That is the purpose, honestly, of the clinical practice guidelines. And of course, the sessions today is for people to learn about these and eventually get comfortable. The thing that I would stress, though, we have so many pieces of the puzzle to put together still. We still need to make sure that we have a way of providing our patients with that lifestyle counseling that goes along with it. And I feel, I'm a primary care pediatrician, and I know that that's a big challenge for me, getting patients invested and offering them the resources that they need to accompany medication use. But I think that this is something that should be happening soon. I mean, that's what the guidelines are saying, that we should be doing this. Pediatric healthcare providers should be offering these medications to our families. I think, honestly, the biggest thing is really making sure it's done in the context of lifestyle counseling, intensive lifestyle counseling, and close follow-up.
So we have permission, is what it sounds like.
Yes, and I will say for the afternoon too, to even think about, I know some of our subspecialty colleagues are going to be talking about other medication options around hyperlipidemia, hypertension, right? And I think this is something, as we see these rising numbers of obesity and cardiometabolic disease in children, it is not necessarily something that we had in training, but this is something that our internal medicine colleagues do all the time, and I think that we can do it too, right? If we see these issues in our patients, we can be the ones to start management.
I would just add as an editorial comment, I think two things. One, we never really have had recommendations or access to medication therapeutics to even introduce into a primary care practice setting. So that's part of why we're convening today's session, to start to learn about that. I think it's really important to recognize the challenges of really trying to integrate this into busy primary care practice. So, you know, if there's 1 million kids in the DMV and 1 in 5 are significantly overweight or obese, that's a lot of kids. And, you know, conceivably 20% of the kids in your practice, if you're seeing 80 to 100 kids a week, you're going to be seeing a lot of boys and girls in whom weight is an increasing concern. So figuring out how we begin to sort of build that into our visits, our conversations, our workflow. It would be great if we could franchise this ideal expertise and put one in each one of your practices, but it's not going to happen. You know, we're doing this way more organically, really across the care continuum, and really trying to sort of figure out how we begin to do that. We can't refer it all. There's just no capacity to sort of address all that, which means we are going to need to sort of learn the rubric. We need to learn the protocols. It isn't going to be medication alone. It's got to be all sorts of lifestyle issues. And part of our lunch session will be in a session about engaging patients and families in change in motivational interviewing, because if they don't want to do it, it ain't going to happen. And so that's part of what we need to sort out as well. The insurance companies are often reluctant to start approving and adding medications to their formularies. You know, they'll say, we didn't budget for it, you know, and they didn't. But all these other adult medicines come out, and they manage to sort of figure out how to do that. And so there's that. The second thing we've heard from some of the payers is, well, that employer doesn't want it covered under their work benefit. So those things aren't covered by their employer. And I share this with you because we're often, you know, tearing our hair out trying to sort of figure out how we're going to sort of develop the right sort of integrated plan for this child and family. But sometimes you need to remind them that they actually need to go back to their employer and their employee benefits officer and say, this needs to be covered. This is not some incidental, non-medical thing. This is germane to my health today and tomorrow and my family and whatever. And we have to keep exerting pressure across the care and payment continuum if we're going to move the bar. Because we're going to be wasting a lot of our time or our practice staff time sort of chasing down all these pre-auths and this, that, and the other stuff. And that's just a waste. You know, so I'm encouraging some shared awareness, some advocacy, but also we need to keep challenging the payers to sort of move on this, because otherwise it's just going to be, we're the ones going to be having to sort of continually solve for what should be covered and isn't. Is that too much of an editorial, or are you guys?
Well, I'm going to add on to that, because this refusal by insurance companies to pay for these medications that are effective is really based in bias and stigma. It's the belief that you just need to decrease your calorie intake, increase your physical activity, and we know that it is far, far more complex than that. And so seeing how, when you see patients who really benefit, it's quite remarkable. I do also want to stress that it's very heterogeneous, the response. So, you know, I presented some really exciting data on semaglutide. I've had kids who've gained weight on semaglutide. So it's really, everyone is different. It just needs to be, we really need to have a very targeted, individualized approach.
Hi, Ben Gitterman from Silver Spring. My knee's hurting. Ben Gitterman from Silver Spring. I have what I feel like is a second generation issue question with this. I've been lucky enough, and I've gotten several kids medication approved, which I'm very happy about. And using with those kids a reasonably integrated approach to IHBLT. The crisis I've come up with is in 4 cases now. Their family has had, because of jobs, to switch insurance. So they've been covered, and now they're not. And one of those was in a public insurance situation. The other 3 were privates. In each of those cases, the kids, to put it mildly, emotionally went bonkers. And it was really horrible. It was really frightening. And we had behavioral support and all of that sort of stuff. And I really wonder if you've dealt with that yet or had to deal with that. They're on it and all of a sudden it's taken away from them because the parents can't afford it. Or are there other side effects to worry about if you medically, physiologically, if you suddenly have to stop these medications?
So my experience has been, honestly, when we have had medications that have been covered and then are not covered, is that the initial coverage was actually by accident. I truly believe that because I've had families where we've sent things in and all of a sudden they got coverage. As far as what we worry about, it's just the return of a lot of the comorbidities. So and it's unfortunate.
Yeah. And I'm curious, do you mean like you worried about the side effects from stopping the medications abruptly, or it was more of kind of emotional distress? Yeah, I mean, I will say so, is depending what they are. Some of them certainly are centrally acting, similar to patients that may have been on SSRIs or ADHD medications for a long time. I think if they are stopped very abruptly, you can have some withdrawal symptoms, but that's typically, I think, less discussed and described in the literature, not something I've necessarily seen too much in terms of kind of a psychosis or things similar to other mood stabilizer medicines that have been stopped abruptly. But I could certainly see that if, for someone on like Vyvanse, I've actually had patients go off on very quickly and not have any adverse effects.
The recommendations for topiramate, though, are to go off that slowly. There's this theoretical risk of increase of seizures, so that's the one where you need to taper them off. But are you referring to more the GLP-1s that you've gotten coverage, and the children were upset because they were doing so well on,
Right here, Perdita from Weston Pediatrics and NIH. Question, it kind of dovetails on one of my colleagues talked about. I think ultimately we will be doing this, like psychiatry and all of the things that we do now. And so long-term, are there safety assessments we should be doing on these patients, labs or other things that we should be looking for the medication effects? And is there or should there be like registries for these studies, these drugs, as far as patients on them?
So really good question. Long-term, as far as monitor, we want to continue to, of course, monitor their cardiometabolic progress. Individuals who are on topiramate should have periodic metabolic panels to assess for metabolic acidosis, so we should be monitoring for that. And then a lot of it is it's medication dependent. So for example, someone I put on metformin, I always want to check an ALT periodically for hepatic toxicity. So it really depends on the different medications. As far as long-term data, we don't have a lot of long-term data in the use of these medications in children for obesity. And yes, we should be seeing what we need to be monitoring them. I mean, I have parents who are very, very reluctant to start medications, and it's really a risk-benefit discussion, given what their risk is with what we have right in front of us right now, as opposed to theoretical risk in the future. And so I by no means would ever say that this is without risk.
Hi, I'm Anand Dalaki from Silver Spring. My question was back here. My question is around, given that the studies were done in the context of intensive lifestyle counseling and other interventions, the question I think is about that is, how have you incorporated that into your support of these patients with medication? And how have patients engaged in those other interventions, given that they are being offered a medication? How does that affect their engagement in other things? And any issues that you're running into there? And then and also, I think, just accounting for all of the social determinants of health that we heard about in the morning. How has that gone in your practice?
So a lot of great questions. I can say that in our clinic, in the Ideal Clinic, when we start children on medication, I would love to see kids every 2 to 4 weeks. We don't have the capacity for that. So we see kids usually every 6 to 8 weeks. And usually children, I like to think success begets success. So if you are taking something and you've been struggling with this your whole life, and you take something and you start to see progress, you are probably more likely to go back because you think that maybe you are getting the care that you need finally, right? And so I have not had kids who, if they are doing well, they are willing to engage and be part of the process. Typically, attrition rates are actually fairly high in pediatric weight management clinics. In the research setting, about 40%. In real life, can be up to 60%. So we're battling that as well. So it is a real challenge trying to get families engaged. But that's what our practice is. So I see patients, I try to see patients, and you probably do the same, about every 6 to 8 weeks if they're on medication. Try to maybe squeeze in some visits with just the dietitian or some telemedicine visits, but we really want to monitor patients very closely. I don't know if I answered all.
Yeah, and I would say we are fortunate to have the capacity with our dietitian. So particularly with patients on a new medication, I will usually have them follow up every 4 weeks for the first couple, 2 or 3 months to kind of monitor for side effects, and also meet with the dietitian intermittently via telehealth to kind of reinforce some of those changes. Was there anything we missed? I feel like it was a multi-part question.
It was all about the everything besides medication. How does it go?
Yeah, and what the other thing I will say, similar to what Dr. Vaidya mentioned, is that I will often kind of encourage patients that may have felt really frustrated or sort of given up in the past, and where, well, we know that there's something physiological going on, right? It's not to say that I don't believe that you tried to eat healthy before, that you tried to exercise before, and I understand it didn't work for you for all these complex biological reasons, but I'm going to give you a tool to hopefully help that biology piece of it, and I really want you to try again, right? Like, let's get in with the dietitian, let's go back to these changes, because this time it really may work for you. I can't promise that, right? Everyone's body reacts differently to these medicines, but it's a much better chance than you had before, and I find that's really encouraging to patients.
Hello, my name is Veronica Vella, and I work in healthcare transformation, and I have 2 questions for you. One, I'm interested in programs that serve those who are uninsured, and wondering if, for example, like the Montgomery Cares program that's for kids, are they starting to cover these kinds of drugs? Do you have knowledge of that? And then my other question gets back to this whole of the lifestyle intervention. Are there specific studies that demonstrate a model for the kinds of lifestyles? I mean, so it's one thing to say, like, follow up with a dietitian at this period, but are there specific programs, durations, intensities, any sort of research studies that you all could point us to so we can look at lifestyle intervention models that would be coupled with a medical intervention?
Yes. So in terms of the uninsured coverage for medications, that I do not know, and I would assume not, because I think even with Medicaid coverage, it's difficult. From the programs, though, and I don't know if you had a chance to take a look at the website from earlier that the Institute for Healthy Weight put up, but those programs that were cited in the clinical practice guidelines, the MEND program is sort of one of the big ones that's modeled after the strongest trove of evidence, but looking at sort of kind of across the country and over many years of these programs that multiple institutions have done, we do see, definitely patterns of what is most effective. So those programs that kind of meet that longitudinal piece at a minimum of 3-month time period up to 12 months with a maximum amount of contact hours, at least 26 contact hours over that time. Up to 52 has been shown to have the most maximal benefit, but that I think is less practical for most practices. So they've kind of gone with that minimal piece of the 26 contact hours, family-based interventions. So those kind of markers that were found across multiple studies. And so there are definitely programs that have been modeled over what those kind of markers have been that are replicable across practices and are available to implement through modules that are available online.
We have time for 2 more questions, one over here, and then I see Dr. Hopper, and then we have a couple more things to finish before noon, so.
Елена Балакирский, Baltimore. I have 2 quick questions. So how young was your youngest patient that you start on medications? And the second one, how often do you follow up with the blood work when you start?
So that's those are 2 great questions. As far as how young, I have been doing, I think we started the Idea Clinic back in 2008. So I've been doing it for a long time. I've had the privilege of having talked with people all over the country who are doing this same thing. And there is such variation with people's comfort levels with how young they will start medication. I will tell you that I have started topiramate and Vyvanse in kids down to 6 years of age in situations with someone where a child had some significant comorbidity and had class 3 obesity. And actually even younger. No, I've started Vyvanse on someone even younger. Some of the other medications, phentermine and topiramate, I am a little more hesitant to start in younger kids, but I have colleagues who start them on very, very young kids. So there is a huge range for which these medications, for the use of these medications, as far as its comfort level. So I'm probably a little more conservative. And what was your other, did you have another question? Oh, how often do you do lab work? And so it depends on really how abnormal the lab work is. I think it's reasonable to do lab work yearly unless you have significant abnormalities such as hemoglobin A1C in the 6s. In those kids, I may want to do it a little more 3 to 6 months, depending on progress. I use progress as a barometer. So if I have someone who's doing really well, made a lot of lifestyle changes, maybe the acanthosis is starting to fade, I may push off the labs and I kind of do it on a case-by-case basis. Anything?
Dr. Hopper.
Kind of comment and also question I have about the best, especially the injectable ones, the semaglutide.
Mm-hmm.
It's exciting that it seems to work so well, but it makes me really worried about the price. Like, I'm on the finance committee with PHN, and they're looking at us every single contract, like how much money are you spending? And so if we start to get these approved, we're looking terrible to them because, we're spending 10 times as much money as everybody else is. And that's terrible. It's kind of unethical, I think, that these companies have, not just the insurance companies, but that the company that's made this is making it so expensive for something that would work for 20% of the population. But it is a really high bar. I don't think we're going to get lucky enough to get them approved much. So, and it's an injectable thing, and yeah, I guess you have to teach them how to do it. So I guess I'm wondering if we're looking at all of us as a big group thinking about prescribing, should we be thinking more maybe the easy bar to jump over a little bit is this topiramate and phentermine? Maybe that would be something we should all focus on a little bit, is maybe there's a stepwise approach. You would think that if they're going to eventually start approving these, maybe they'll approve the cheaper thing first, and then eventually they start. So that was kind of I'm wondering how can we, if we want to start doing medication, because it does seem like we should be, just like we're now learning to do all the other medications. But what are your thoughts about that?
No, I absolutely agree, and I do tend to actually fall back on phentermine and topiramate.
One of the times where I feel like I like the GLP-1s better are kids who are on other medications or who have, for example, a significant anxiety or on SSRIs and other medications. In those situations, I'm a little bit hesitant actually to put someone who's already on a stimulant who has ADHD. I don't want to put someone who has ADHD and is on Concerta on phentermine. So there are some significant limitations with kids if they already have medications or things that may cause cumulative side effects.
Yeah, I will say a couple things. These auto injectors are very easy to use, and I actually have a lot of families, especially for kids that have some special needs, kids that are extremely hyperphagic, that have a variety of syndromic features as well, that they prefer the injectables. It's very hard to get some of these children to take medication. These auto injectors are used more and more commonly in a host of conditions when we think of all the patients that are on, Humira, that are taking these treatments for type 2 diabetes. They're becoming more and more common. Almost every family that I talk to, when I mention how they're used, oh yeah, I'm on XYZ for this condition, grandma's on XYZ for this condition. We've seen those pens before, right? They are getting covered in the adult world for a variety of conditions. So we can pay for them for kids. We just have to have some will, I think, to do it.
So we're sort of at time, but these folks will be available at the hallway or whatever. We have a last little 10-minute segment that we want to sort of get in before lunchtime. First, a round of applause and thank you to Alicia and Susma.